This is a very short abstract of the bigger lecture on T-scan occlusal analysis, and this is a case specifically describing intervention on a patient with masseter hypertrophy. So the patient presented with the history of orthodontic treatment in the past, and she was wearing lower bonded retainer, and she was complaining on her left masseter being excessive and prominent. So the intraoral assessment revealed that she had her number 15 in a crossbite, in a full crossbite, so that its palatal cusps were fully covering the facial of the lower second molar on the left side. The T-scan occlusal analysis on the same patient revealed that she had contacts in her right and left lateral movements on both second molars. So the left side second molars, the pair of upper and lower second molars, the same as the right side pair of the right upper and lower right second molars, they were engaged into balancing and working interferences. But because the left side was excessively in a crossbite, while the right side was in normal intercuspation, the left side had to be addressed at that point. So our decision was to do segmental orthodontics. We put the palatal anchorage with the transpalatal arch, and we put some brackets on her number 14 and number 15 to align those teeth and not to disturb the already formed and arranged occlusion by putting that transpalatal arch that was holding the first molars in place and that intercuspation that she already had. So with this intervention, with this segmental arch, the main purpose was to align misaligned second molar on the upper left side. Having done that, we were anticipating the interferences, the balancing and the working interferences to be significantly corrected. We couldn't interact with the T-scan from the beginning because it was the tooth misalignment that couldn't have been treated with occlusal adjustment alone. It would cause the increased enamel reduction and even dentin reduction in that patient, and it was not justified in that case. So the very first decision was to align the teeth properly and then to check once again what happened and how the interferences were corrected with that orthodontic intervention. By decreasing the amount of interferences and the number of interferences on both the balancing and the working movements, we decrease the involvement of both masseters on both sides in those lateral movements. So the temporalis muscle, the anterior temporalis muscle, is the only one that has to be engaged, of course, together with the pterygoid muscles, but not the masseter. These are the muscles that have to be engaged into the lateral movements, but not the masseter, which is the pure and static muscle, which is the muscle that closes the mandible, that is controlling the static movements, but not the lateral and functional movements to that extent. So we followed the patient, and the alignment was done within 2 to 3 months. And after debonding the patient, the second molar continued to settle down. And the more we see cases like this, the more we conclude that whatever the second molars are in a favorable position, they tend to settle down, and these teeth are those that have the highest number of interferences and the contacts with the highest forces throughout the whole dentition. And whenever there is a misalignment of the second molar, it has to be aligned. And if it's even in a higher position, if it's even in a supraerupted position on the upper arch, this second molar will settle down very, very quickly. So this is the patient with the improved left side, although the right side still needs to be taken care of.